Good morning. How you feeling? Are we feeling good? That's great. Hey, what better place would you rather be at Torrey Pines on a Saturday morning? Right here with your buddies. Uh, and then you can go play golf or do whatever. I'm George Johnson. I'm a facilitator today, and I'm here to introduce what we do here and encourage you to keep coming back. We have a wonderful roster of doctors coming in here, and we have a great speaker today. And let me first start off by thanking the Sanford Burnham Previs Medical Discovery Institute. We're going to be discovering things, and they provide these facilities to us, so I'm sure you'll be attentive to keeping it clean and so forth. They have other facilities. They're in the back door here. You walk down a quarter of a mile to the restroom. And also, I'm going to ask you to shut off your cell phones. Now, somebody suggested I require that those whose cell phone rings during the meeting, you must stand up, answer the phone with your full name, and ask the person what their PSA is. Okay? So if you want to avoid that embarrassment, please shut it off. Okay. Here are 10 guys that work for you. Lyle can't make it today, but Gene is here, and he's going to be saying a few words in a few minutes. And I'm the third guy there, George. We got Bill Manning, who's also a director, but he's also a video director. He's got that black box with the red light on it. And then we got John Tassi. He does the website. He's in the back there. And okay. Steve, where are you, Steve? Does a great job on the newsletter. We got extra copies out on the back, and it's got some research results and some old jokes. And I don't know what's more important for this program. We got Bill Lewis, who does a summary of the meeting, and there's Bill back there. These guys put their time in. And then we got Bill Bailey, and the thing about Bill Bailey, he's a believer in exercise. He has these huge boxes that he brings in for you every month. Look at this display of wonderful library material. Some of it's free, some of it you can rent, and more importantly, some of it you can buy, and we rip off a couple of bucks off of it to help our program. And really great stuff here. And then Chuck Grimm. Chuck Grimm is right here. He's the guy that plugs in all this stuff so the computer works and we get this projected. It's not easy because frequently things are shut down here, so he's a great asset. And then Jim. Where's Jim? He's greeting people. There he is. He's the guy with the smile, and he has a handout. All the newcomers, they get a new handout there. There you go. You've got a lot of information there, fundamental information you'll need, a glossary of terms. And so everyone here is a volunteer. The salary's terrible, but the benefits are great. And if you want to join us, see me after the meeting. Okay, the Newcomer Package, I just asked about it. There's a yellow cover sheet. Fill that out. Bring it up here after the meeting. Gene will give you a call. He's a comfortable guy, and he'll answer any questions you have. And because we want to get to know you and help you get to know us and the network we have. What do we do here? Our primary mission is we're patient-focused. We have doctors come in and see us and talk to us about things, but you're all a bunch of patients. And then you have spouses that are also hopefully patient with you. And the whole idea here is you must become your own case manager. You got to manage your case. The doctors have 3,000 or more patients. And so you're the one that has to keep a copy of your lab reports. You're the one that has to figure out, I think I need a PSA, and remind them. You're the one that has questions, write them down, bring that in a notebook with your lab reports and so forth. What we try to do is help you not to make a decision. Well, that's not our job. Help you ask questions of your doctor. He's the one that should be helping you. So that second paragraph is meant so you can't sue me, okay? Fundamentally. So we're not a substitute for your doctor. He's the professional and so forth, and he's the one that you need to ask the questions. And maybe we'll be helping you in coming up with those questions. Okay, our support to you, we have this website that I've mentioned. It's really good, and it has profiles of some of us in there about our cancer. A wonderful collection of things. It's been modified. It's really easy to use now. And then we got our table down here, and the newsletter, I've already mentioned that, outreach. Gene gave a talk to a group last month, and we're available to your Rotary church group or whatever, a snappy 20-minute talk on prostate cancer. So if you'd like to spread the word, and we'd like to do that for you, contact us, and we'll be happy to do that. And it's also your responsibility to spread the word. Grab a brochure, because your buddies, if you got prostate cancer, one of your 6 buddies has it also. And you want to encourage them to get a PSA test. You do an outreach and help you and your. Now, oh, by the way, if you got sons, there's a tendency, a hereditary tendency. If you have cancer, the probabilities are a little above average for that son to have cancer. So bug him about getting a PSA if he's over 50. If he's because of the hereditary thing, you may want to do it before 50. Okay, monthly meetings. A drum roll. Our next speaker, Dr. Schwartzberg, is going to talk to us about new focal therapy. It's called irreversible electroporation. Did I impress you? Wait till you hear him. He's going to talk to you about a very good technique that was created in Germany, and now he's starting to do it here for you. And I'm thinking about it. And after that, we have another speaker. This one is on new diagnostic techniques, and we've got a rundown on all the new techniques that you need. Detection is very important. Okay, I'm going to ask you some questions, and I want you to raise your hand if appropriate. How many are here for the first time? Raise your hand, please. Okay, keep them up here. Your seatmates, look over, say welcome, and talk to them about it when at the end of the meeting. Okay, how many have recently been diagnosed in the last 6 months? Well, welcome, welcome. You're going to be discovering some things that may be helpful, particularly with today's speaker. And how many have had prostate cancer for up to 1 year? Okay, so we got some newcomers, and now let's go up to 4 years, up to 4 years. Now we're building the normal distribution curve, 5 to 10 years. Now we see what we got here. Okay, 11 to 15 years. Okay, now we're in the downslope. Who's got more than 15 years? Raise your hand. Okay, I got 21. Okay, anybody beat me? 25. Anybody beat 25? Do I hear higher? Jack, okay, Jack, how many now? 28. 28, you get the grand prize. Jack was a speaker last year for one of our members' presentation. Great story. Look at the smile on his face. He's a happy guy. So you newcomers, look what you got to look forward to. This is a wonderful program, and it works if you work it. Okay, we'll just do our traditional treatment survey. This is for the newcomers, and also our guest speaker who would like to know what the profile is. How many have not had treatment but are currently on active surveillance? Raise your hand, please. See how many we got. This is growing, and that's good news. It's good news because it means they haven't had treatment. They don't have any side effects yet, and so forth. That's the real treasure about active surveillance now. If you got a Gleason of 6, you're a real good candidate for active surveillance. Okay, surgery of the prostate, all kinds. How many? That's been the gold standard. Now let's do radiation of all kinds. See, now we're doing more radiation. And okay, ADT. Look at all that ADT, huh? Oh boy, I've got some follow-up questions on that. How many are on chemotherapy? 1, 2, 3, 4, 5. 5 on chemotherapy, or have been on chemotherapy. That's not a continuous flow. Okay, I want to cover new treatments in a little bit. How many have had, after treatment, have had prostate cancer recur? Raise your hand. Look at that. See, now don't be discouraged, newcomers, but this is why you need to get a PSA even after you had treatment. Okay, how many are undecided what to do next? Okay, see, so we got the right guy to help you figure that one out, and because we're going to hear about a variety of treatments. Okay, I got some additional questions. All of those who raised their hands on ADT, raise your hands, all those who are or have been on ADT. Okay, look at that. Okay, let's run down the, what I call early, and these were the standard. I'm going to use brand names because most of you know that. You don't know the generic name. How many have been on Avodart? I have been. On Casodex? Okay. How many have been on the injection Lupron? Look at that. I haven't. I had it once. How about another version of that, Trelstar? Okay, that's what I had. Firmagon. Look at Firmagon. Not that many. Why do I have that? No, I tell you why. Okay. How many have or did have CRPC? How many know what CRPC stands for? Castrate-resistant prostate cancer. In other words, you have a rising PSA and you're on ADT. How many have that? A rising PSA on ADT and you're on ADT. See, that means their castration effort of the ADT is not working. Your PSA is rising. So this is then you're a candidate for advanced ADT, and these are their trade names. I'm not going to talk about them because our speaker will, but I'll give you a trade name, Expectancy. How many have been on or have been on Expectancy? Not very many. All right, how about Zytiga? I misspelled that, Zytiga. We got maybe 2 or 3 more on Zytiga. Zofigo. First, can you pronounce that? It's Zofigo. How many are on Zofigo? Just you? Okay. Provenge. How many have been on Provenge? Okay, we got about 7 or 8 there. Keytruda. 1, 2, 3. That's brand new. And, 4. There's another one over there. Okay. Okay. Anyone here with CRPC, castrate-resistant prostate, without metastasis? In other words, it has metastasized. It has not metastasized. It's still in the pelvic area, but your PSA is rising. How many have that? I do. Okay, 1. Is it rising? Well, when you're on intermittent, it rises, right? Okay. Has it metastasized? No. All right. So you're one of those. Who else? Okay. Well, how many we got? This is because I got it. All right. Okay. Anybody here? No. How about there? We got 1, 2, 3, 4. Okay, 4. Okay. We're a rare breed because if you don't have metastasis, what do you take? What are you taking there? Okay, you're still, okay. Is there any alternatives, anything new that you could take? Okay, over there. Two days. I got an extra day on you. That's brand new. We're going to be hearing about that. Okay. All right. So up till recently, like 3 days ago or something like, it was announced as FDA approved apalutamide, called Erlita. It was approved in February, and the New England Journal of Medicine has an article on it this week. So it's brand new, so there's hope on the horizon here for us, because we didn't qualify before. Our speaker had a chart showing the various degrees of prostate cancer, and there was a column that was empty. And now there's apalutamide is in that column. And thanks to our speaker, that's what I started taking. And so I'm looking forward to hearing it. It's called Erlita is a new one, for those who have not metastasized. So that's the good news. All right, we need your support. This is a time to show your appreciation. And I know that when you filled out your tax return, you said, oh my gosh, I should have contributed more to the Informed Prostate Cancer Group. So don't make that mistake this time. Dig deep. We're tax deductible, and you can have tax exempt. If you need a receipt or anything like that, we're happy to provide it. We have small baskets, so we need big bills, okay? We got Steve's going to work this, and Tim will work that, and go down, pass it down, does this remind you of church? That's what we're doing, okay. And we like bills with zeros on them, okay? Basically, for us to break even when we don't want to dip in our reserve, we'd like to average $10 a person. So if you got some loose change, we'll take that too. Let me just remind you of what our principles are. We have 6. Early detection, get a PSA. Keep getting your PSA. Don't do what I did. I stopped for 2 years. My PSA went from 0.7 to 14 in 2 years. I very accelerated doubling time. If I waited a year, it would have gone, another year, it would have gone to 200. If I waited another year, 2 years, it would have gone to 3,000. So that shows you, my doubling time is 3 months. That shows you how important it is to get a PSA. Okay, and then you need high definition diagnostics, and we have had a number of speakers, and we're going to have the month after this one coming about that. And then if you got that, do a targeted biopsy, so then you can really get an accurate measure of your Gleason score. And that's a key to decide what kind of treatments you have. You got 6, you're a prime candidate for active surveillance. If you got a 7, 3 plus 4, 4 plus 3, you probably want to get a second opinion on that. And that sets you on a course of what kind of treatment. And then we're going to be talking about that. And let me do because we have such a good group here, we have an opportunity to do networking. And I have a networking question. I'm curious for myself, and let me give you an example. I learned from Dr. Schwartzberg 2 weeks ago that I have what's called prostate cancer of the rectum. I have rectal invasion. Anybody else have that? It's not rectal cancer, but prostate cancer of the rectum. Anybody have that? It is rare. Well, I do, and so that's why I'm looking forward to today's session. Anybody else have a question they'd like to have a network on? A question. Somebody was interested in how many have had proton therapy. Raise your hand. And if you're thinking about proton therapy, look around and see if somebody's next to you that you want to talk about, and so forth. And that's the purpose of the network. Get a rundown on that. All right. Before I introduce today's speaker, Gene would like to say a few words.
Okay, I'm still fondling the money.
He's got a big bag there. You need an armed guard.
There, we got this one on, right? Thank you. I just wanted to mention a couple of things. George already mentioned that a couple of weeks ago I was invited by Verl Peterson to speak at the Community Covenant Church out in El Cajon. This is the first time that anyone has asked us to speak for over 2 years, as far as I know. And it just lets me take this opportunity to say, if you have a church group or a Rotary group or whatever, we're more than happy to come in and talk about our disease and what people need to do to help themselves avoid having a serious problem with the disease. Verl, are you here today? I don't see him, but thank you very much for that. 20 people showed up, and it was very well received. So one of the hardest jobs we have is outreach, to get new people to come and understand about dealing with our disease. Got a few new books in the library, one called Prostate Cancer, Asking the Right Questions. We just got that, so that's available in the library. We've had this in the library for some time, The Key to Prostate Cancer, written by Dr. Mark Schultz. Very well written. He's with the prostate oncology specialists up in Marina del Rey, and also the founder of Prostate Cancer Research Institute. So I take advantage of that. It's a very well written book. And we just, the newest issue of Pact magazine of our friend in Grand Rapids, Michigan, that runs the support function in that area, and it comes out every quarter with a new newsletter. And there's one very interesting article in the back about testosterone. There's so much conflict about how good testosterone, how bad it is, and it's really well written. I don't know that I got any conclusions out of it. All I know is that probably in my case, if I hadn't reduced my testosterone, I probably wouldn't be talking to you. But it's not necessarily true these days. So now that one quick one, is Dennis Zinger here today? Oh, there you are. Okay. Turn around and meet Larry Weaver. He's been looking, he wanted to meet you. You've talked, but you haven't met. Okay. So I did my job now. You'll pay me later, right? Okay. Okay. All right. That's all I've got to say, other than the fact that I was counting heads earlier and we're well over 100 people here today. That's outstanding. Thank you very much.
All right, I'd like to just introduce our speaker. And normally at a prostate cancer conference, they announce any conflict of interest working for pharmaceutical companies and all that. I have, you might think, a conflict of interest, but it's a mutuality of interest, known as my health. Dr. Dato is my doctor, and I think about him often. I think about him particularly after the midweek, for a couple of weeks thereafter, because every month I get a Firmagon shot right there, and the pain is there for about 2 weeks and so forth. I cannot take Lupron, and he recommended Firmagon, which is working well for me. And now he's with the Genesis group. He's a medical director of it, formerly the director of the clinical studies for Genesis. He's a California guy. He was a native of San Diego, went to UCSD around the corner here, and then drifted down to Tulane. I don't know that story, but then he came back to University of California, Davis, to get his specialty, and then it was up at the Oakland Naval Hospital to get his residency in urology, and served 25 years in the Navy. And you reminded me, my doctor was a Navy doctor. They're good doctors. He achieved the rank of captain. Welcome aboard. And he's going to talk about the decision factors and some of the things that were on the slides here. So let's give Dr. Dato a big hand. Thank you for coming.
Well, good morning, everyone. Nice to see some friendly faces out there. I'm sure you brought your baskets of fruit that you can throw at me at any time. I was asked to give this presentation today on some of the things that we think about, and we have the frank discussions with our patients when we have a diagnosis of prostate cancer and during the course of the disease. Hopefully, it's a very, very short course. That's our intention, clearly, when we make it. Unfortunately, since some misguided recommendations came out of the United States Preventive Services Task Force back beginning 2008, 2012, and updated, I think it was last year. We've unfortunately seen a lot more men showing up on day one with either higher grade or higher stage disease, and we're seeing a number of men already with metastatic disease when they came in. This last week, I've already seen 2 men. Which I think is tragic. We believe we can make an impact on this disease if we can catch it early enough. So these are problems that we have to deal with, and of course we take the entire spectrum of the disease into consideration when we're speaking to our patients, and as we go forward here, I think you'll get a bit of an idea about that. So decisions, it clearly is becoming a much more complex disease. It's not the same disease when I was doing my residency back in the late 80s, and I finished up in 91. It was pretty straightforward then. You either operated, you radiated, you gave hormonal therapy, and that was about it. And if you progressed, it was unfortunate, but we didn't have anything else to be able to offer. So there's just been an explosion of data, both on the basic science and the clinical sciences, as well as new agents that have been able to assist us in offering more treatments, especially in advanced disease, but newer concepts and ideas also in early disease. For example, when I was in my residency in the early 90s, you made a diagnosis of prostate cancer, you automatically got treated. Nowadays, we have active surveillance. We can do something. We can avoid a lot of the morbidity that's associated with our treatments from that standpoint. So that's been a major breakthrough for us and helped our patients. So our options, regardless of where we are in the spectrum of the disease, whether we're early or with an intermediate risk, low risk disease, they can be very overwhelming for our patients. They can be that way for urologists as well. That's why we in Genesis have elected to try to get this more specialized and have a specialized office and clinic to be able to help our patients a lot more from that standpoint. It's very, very difficult in the busy general urology practice to have the time to be spent that we need to have these kind of frank discussions with our patients. When you're seeing 30 to 40 patients a day, it just doesn't leave a lot of time. And the time that you as the patient, I believe, deserve to go through all the aspects of your disease. So it clearly can be overwhelming. In high risk or metastatic disease, maybe somewhat fewer options, but nonetheless very daunting because of the implications that the treatment or lack of treatment and which choice that you make has, and ultimately not only in the treatment of the disease, but in the quality of life. And we're becoming more and more cognizant of that to be able to think about those things and present those options to our patients so they can make an informed decision for themselves. So this is what we consider a classic PSA roller coaster type screen with a little bit more information added. And it's really a breakdown from the point of time from diagnosis. Let's see, I think this is it. From down here, where patients are typically diagnosed, typically asymptomatic, typically non-metastatic, and everyone is hormonally sensitive, whether they present with early disease or whether they present with metastatic disease. They're all hormonally sensitive for about 99.9% of prostate tumors. And as we move along the timeline here, we start to see situations where therapy has been provided. If patients unfortunately progress, they may go on to hormonal therapy, and then all these other agents here that have now been brought on, and more being brought on all the time as a result of a very intense focus on clinical trials to develop new agents for ourselves. One of the bigger things that we've been seeing more recently is the use of medications which have been approved for use much further down the line, much further down the time frame, and now are being used earlier since they've been found to be efficacious. Some smart people, some bright people have decided, well, maybe we should be using these earlier. Maybe we can prevent the progression of the disease. So we're seeing not, in the older days, we used to see a sequence of therapies. We would start with one. If it didn't work, then we'd move on to another and another and another. The current some of the thinking now is combination therapies. So we're starting to put two different types of medications that are designed to work on different aspects of the cell cycle of the prostate cancer cell itself. And so the idea is that, and we've found out that prostate cancer is not all vanilla flavored. We've got vanilla and chocolate and strawberry and lots of other flavors. We have different subtypes of prostate cancer, and they behave differently, and they can be present at the same time within a given patient. So if you're trying to then get this under control, ideally you'd want to get all those different subtypes or clones of prostate cancer to be treated at the same time. Theoretically, if you wiped out every single clone, you'd be able to wipe out every bit of prostate cancer and achieve a cure. We're not there yet, but clearly that's the direction that we're going as we develop more and more information about the basic science and the basic pathophysiology of prostate cancer and the different subtypes and how they behave. So we've got immunotherapy down here fairly early, but we know that immunotherapy is starting to be used much later after a failure of standard hormonal therapies, when androgen independence develops initially castration-resistant disease, then actual androgen independence. We still have chemotherapy agents that are still available. Again, some of them being used much earlier currently as a result of some of the key clinical trials that have come out within the last 3 years, thinking of Charted as well as Stampede and the Latitude trials, to be able to use chemotherapy earlier with hormonal therapy in men who have metastatic prostate cancer when they present on that first day. And we've clearly seen significant improvements in overall survival in those individuals. I'm going to be talking about ERLEADA a little bit at the end as a sideline, and in spirit of transparency, I am a speaker for Janssen, in addition to several other pharmaceutical companies, but I'm going to give you the basic information. I'm going to try my best to do it in an unbiased fashion, and any questions I'll be more than happy to discuss with you. And it's any time, too, during the conversation. Please shout out, hold up your hand. We're happy to go through those. So again, as we move forward here, what are we thinking about as we consider treatments for our patients? There's a number of things are listed here. We're going to go through each of them with a little bit more detail, but we'll look at the age and how long do we think someone's going to live. That's a very difficult topic to try and get your hands and your head around. I'm not the almighty. I know some white coat people tend to think that they may be. I know that I'm not. I don't know the answers, and so we're going to look and use a lot of information to try and make that determination in an effort to determine what is the best therapy for a given individual. We're going to talk about what the co-morbidities are. Those are the concurrent active medical problems that a patient may have that's going to can influence lifespan. It can influence what medications we choose, a number of factors here. The stage and the grade of cancer, clearly. For you in the Informed Prostate Cancer Support Group, you know what your Gleason score is. You know what your numbers are. You know what the stage of the cancer is. Those are things that clearly that we're going to use, and many of the guidelines use that information as well to provide us advice and guidance to what direction we should go. What are the potential benefits? And clearly, what are the potential harms of each individual option that we can look at? And then, of course, and vital, what are your concerns as the patient? What are you thinking about? What's important to you? What are you able to tolerate, and what are you not able to tolerate? Those are factors that the discussions I have with all my patients when we're looking at from that standpoint. And again, all of these are not, even though they're listed here individually, you don't look at these in isolation. They're not separate from each other. They're basically all leading into one another, and one certainly affects the other and has to be accounted for. So if we look at age and expected lifespan, Clearly, what I offer a man at age 95, or actually I should say what I offer a man at 45, I'm not going to offer to a man at age 95, okay? The expectation of that individual to be able to live 10 to 20 years is clearly not realistic. So we have to, so that's why on the extremes, but these are things that we have to think about for our patients. There are some calculators that you can find online. This one I think comes from, I believe it's from Wake Forest, but I wouldn't swear to in a court of law. This one takes into account for prostate cancer and the data for prostate cancer. Other ones are not specific for prostate cancer, but these are tools that we can use as we make some decisions for our patients, more commonly in earlier prostate cancer than later prostate cancer. We can certainly look at genetics of the individual. Question, how long did your parents live? Okay. If you have parents that lived over 100, you're more likely to be able to achieve that. But if your parents had early deaths for some reason, barring something that was an accident or something that was not in their control, then that may be a factor for us. If it was disease related, we want to think about that. We know that individuals, and this is across the board with all types of cancer, those with higher levels of education tend to do better. But that's not always the situation. And so that's a little bit more vague. It's not something that I'm going to think about on a specific basis for a patient of mine, but it's something that we know statistically from multiple studies have demonstrated that. Your income and social status. It's different because for someone, for example, on the extreme who may be homeless, living on the streets, that's a different situation than if you're living in a 4-bedroom house and you've got your mortgage that you're paying that's thousands of dollars. It's a different situation. You can see how that's going to impact too on somebody's health. What kind of health care have they gotten? Where are they at along that spectrum? So those are things that we want to think about as well. Also, when you think about income, unfortunately nowadays, we're seeing a lot of high copays for some of these very expensive medications. Okay? And I'm already experiencing that with my patients. They simply, because of their insurance coverage, they don't have good medical coverage for the particular medication. So their copay, their cost that they're going to have to bear may be exorbitant, and they may not be able to pay for that medication. That takes into account then, therefore, what we can offer them. There are a lot of financial support mechanisms that are in place, but it's not 100%. It doesn't cover everybody. So as we go forward and more medications are being added, clearly because they're new medications, they're very, very expensive. Okay? So we have to think about income from that aspect for it. What are your support networks? Who do you have at home? Are you living by yourself? Do you have a wife? Do you have a family? You have children in the area? These are things that we have to think about with regards to a lifespan that can definitely affect that. Older men who are living alone, they tend to succumb earlier than men who have very, very good support networks around themselves to help them. In my patient population, I've got gentlemen who live on their own. It's very difficult sometimes for them to get to see me. They're dependent upon public transportation or from charity. Those who can get in often have a family member, a son, a daughter. The wife can bring them in to be able to get into. So access to care alone from a social network is very, very important and impacted by that. Co-morbidities. These are the medical conditions that are pre-existing that can clearly decrease life expectancy. If I have a gentleman with congestive heart failure and uncontrolled diabetes, their life expectancy is certainly going to be less than my 80-year-old who's still running marathons, okay? Makes sense. As a result of these comorbidities, we can see an increase in toxicity and side effects of the treatment. The reserve of the individual, the effects of those diseases on that individual can certainly impact that. Hypertension, diabetes can affect renal function. We all recognize that. And so if that renal function is not good, they may not be a candidate for a chemotherapy agent, which can also affect renal function, or other medications that can impact upon that. If I have someone who has hepatic disease, I may not be able to use some of the newer medications, such as Zytiga, because it can affect the liver as well. So these are factors that we have to think about and consider. And clearly, there's a potential for drug-drug interactions. The more medical problems you have, the more polypharmacy you have, the more medications you're taking. Many of these more advanced hormonal agents that we are using nowadays definitely have an impact and are competing, for example, with Coumadin or warfarin. And we have to be very careful from that aspect of it. Some of the other anticoagulants, Brilinta and Xarelto and so forth, antiplatelet medications, also get impacted by or can be impacted by the medications we choose, some of which are not able to be adjusted, such as Coumadin. So I've had some patients, as an example, who are on these other anticoagulants. I've actually had them switched over to Coumadin because I can check a Coumadin level for you. I know where your level of anticoagulation is. So we have to make adjustments on these individuals. Another reason here for drug-drug interactions that we can have problems. When we look here at this slide here, we look at the comorbidities. Cancer itself is a comorbidity. So that diagnosis of prostate cancer may be impacting the other medical conditions just as much as vice versa, the conditions affect the cancer. Okay? There's certainly other long-term conditions. We also have issues here that are not considered a comorbidity, but we have frailty. As we get older, we become more frail. We've been on hormonal therapy, right? And so what does hormonal therapy do? It induces or increases your risk of developing osteoporosis or osteopenia, thinning of the bones, less bone mass. And so if from that standpoint, as well as muscle atrophy, you can become more frail, more prone to falls. We know that there are risks with some of our medications, the newer medications, that increase the risk of falls. These are factors that we have to consider. Functional status here. Are you bedbound? Are you wheelchair bound? Or are you able to get up and move and do whatever you want to do? Those performance statuses are very important as we select medications. Your oncologist will definitely take that into account with chemotherapy because that chemotherapy can have a significant detrimental impact on quality of life. And if your quality of life is already reduced, we're not going to be helping you under those circumstances. As I tell my patients, when we look at treatments for prostate cancer, we're interested in two things. We're interested in quantity and we're interested in quality of life, longevity and quality of life. I consider those two lungs, okay, that we have, and we breathe better with two lungs. We do better if we have both longevity and quality of life. If you have longevity but no quality, I think that's really another word for misery, okay? That's not where we want to be, okay? That's not where we want our patients to be. Okay, so these are things that we want to think about, consider, and as we look at our outcomes from our treatment, how is that going to be impacted by that? Clearly, stage and grade of cancer. We certainly have guidelines that assist us to, as we break down what the stage and what the grade of the cancer is, that would indicate what appropriate therapies would be, what therapies would therefore be inappropriate under those circumstances. We wouldn't offer active surveillance to somebody with a high grade or high stage disease. Clearly, it's not indicated from that standpoint. One of the ones that I think is one of the best guidelines is through the National Comprehensive Cancer Network. I use that almost exclusively. When I make a diagnosis of prostate cancer with my patient, I sit down with the computer screen and we're going over the NCCN guidelines so my patient understands what the situation is, what their risk categorization is, and that's what NCCN does. It gives us a risk stratification for them, and what the therapies that would be indicated or appropriate for that individual on the basis of their information. So NCCN takes into account both grade, stage. It also takes into longevity, breaks it down typically from life expectancy of over 10 years to less than 10 years, and even down to 5 years greater or less. So that's why I think it makes a great aid in terms of explaining information, something visually for the patient can see. They also have a very, very good patient portal for NCCN too. I'm using the professional side of things, but there is a patient portal that you can get onto online, and I think is very, very helpful. Clearly, location, location, location. The stage of the cancer makes all the difference, okay? You heard George mention that to say, where is the cancer? And we have these new imaging modalities that are becoming now available. Some are a little bit still on the outside in terms of availability because you have to pay cash for them, you have to pay money for them. They haven't come into the approval for insurances to cover, but nonetheless, they're all very, very helpful to determine, is this something that is a localized process or is it metastatic? If it is metastatic, is it localized to one place or is it widely metastatic? And more work is now coming out to consider focal therapy even for metastatic disease. Perhaps in one way to be able to avoid hormonal therapy and all the side effects that you who are taking it already know well about, okay? So location, very important, okay? The clinical significance of the grade of the cancer is another word for aggressiveness. How aggressive is this cancer? I saw on another website, is it the small little kitten that curls up and purrs on your lap, or is it the 300-pound tiger waiting to pounce on you? Okay. So your grade is going to give you some idea from that basis of it, in addition to the stage as well. We now have genomic or genetic assessments of the cancer in an effort to determine aggressiveness. We have Prolaris and Genome DX that we can use, give us a little different information. Each of those particular studies, as well as other ones, Decipher and so forth, used in some places and not in others, in some situations that one may be better than the other. But again, it's going to give us some idea, especially in the lower risk disease, if what we believe is a low risk situation is at least has some confirmation, or there's a consistency from what we're seeing both on grade, stage, as well as the genomic assessment. And I think we'll see more and more of these kind of tests become available as we get more experience with them. They can perhaps be better defined and help us define the situation much more accurately for our patients. So what is the potential benefit for each of our options? What is our goal in terms of our therapy? Do we have a chance to cure somebody? Are they early enough that that may be achievable? Or are we really just looking at palliation, just trying to control the situation for as long as we possibly can from symptoms and provide the best longevity that we possibly can under those circumstances, okay? I think part of that in terms of the benefit of the options and which option is chosen, I definitely think there's a physician bias. You've got some physicians, some urologists that I think are more firmly ensconced in the surgical perspective. You've got radiation oncologists that clearly are going to be interested in providing radiation therapy. I mean, that's clearly then in their world. Then you've got some folks that are probably going to be kind of straddling the border. I look at myself right now, and since I'm really no longer operating, I was in the generation that didn't have laparoscopy. So I never learned laparoscopy. I've never done a robotic prostatectomy. I did opens for a long time, up until about 4 years ago, until I injured my back, and I no longer operate in that fashion. So I like to think of myself, maybe I'm deluding in myself, but I like to think of myself sort of straddling the border and be able to say, I really don't have a horse in that particular race from surgery because I'm not doing it, and I'm not a radiation oncologist. So what I'm going to try and do is try and determine on the basis of information, that how well those treatments work, what my patient's desires are, what their concerns are, all those other things that we've talked about already and gone over to say what's going to be a better therapy for that individual. What are your concerns? Again, I've already mentioned about quality, okay? Is my patient somewhat younger? We want to really be aggressive to try and get them the quantity. A younger patient may have less medical problems, less comorbidities, and may be more able to tolerate the rigors of a more aggressive approach. Okay, there was a study that was I think it was a Dutch study, where they were trying to take individuals who actually were metastatic, and they gave them surgery. They provided surgery, radiation, chemotherapy, and hormonal therapy. Okay, the big four. Okay. So you can imagine what the impact on those individuals were. It was a very, very small study. I think it was just maybe about 10 or 12 individuals. And they were able to take individuals who were metastatic and be able to, they think, early on, be able to cure them. eliminate every single clone of cancer on the basis of attacking every known type of physiological pathway that prostate cancer can follow. So, but again, you take that, you give that to a 90-year-old man, how well are they going to be able to tolerate it? Extremely poorly, if at all. So that's what we have to take a look at and trying to make a decision about quantity and quality, try and find a good balance between the two. There's a cost at whatever we do, whether it is from a standpoint of the side effect profile, whether you experience all of them or none of them, to what extent do you experience them, to what extent do they go on after the treatment is completed, things to think about. Talked a little bit about money, and that unfortunately is a real reality that has to be faced for some of our patients. In my group, we deal with patients who have Cadillac plans, and we've got folks who are on the Medi-Cal plans. And the differences are quite striking between them. So we even think about that. As an example of that, okay, we have a bone health clinic that we run as part of our prostate cancer center. So every man within our group who goes on to ADT gets referred for bone health assessment, because we know that ADT can impact bone health in terms of bone density and development of osteoporosis or osteopenia. We actually find a lot of men who even before or right at the start of hormonal therapy, they've been on it for maybe 3 months, not long enough to really have a negative impact on them. And they already have loss of bone mass for other reasons, genetics or otherwise. So we recognize it's a real problem that we have to kind of deal with. Medicare is rather sexist in a reverse fashion. Medicare will pay for a screening DEXA scan, which is what we use to evaluate bone density for a woman as a result of changes with menopause. They will not pay for a screening test for men. So it runs somewhere about $70 to $80. Now, you may think that $70, $80 is not too much to pay for that kind of a test that can give us some real information and be able to help with quality of life. I have some patients who simply can't afford it. You know, they're living paycheck to paycheck. So money does have an impact on, that socioeconomic status has an impact on what we can offer and what we would be able to provide to our patients, okay? There's a time cost. How much time do you have to spend to be able to do this? I have a centralized office down at the south end of Kearny Mesa in San Diego, right across from Sharp Hospital. I've got some North County patients that find it difficult to be able to come in on a monthly basis to come and see me. Okay, so there is a cost from a time, there's a cost of fighting traffic on our freeways, a lot of things to think about that we do think about in terms of what we offer, how often we offer it, how often do we monitor our patients. It's important factors that we have to throw into the mix, okay? Let me stop right there, and I can open up to the questions at least for this first portion of the talk, or I can move on to the next and I'll answer them at the end.
What if you have metastatic cancer but you don't want to do ADT? What are your options?
Yeah, difficult situation, okay? Most of the advanced therapies for metastatic disease are all based on having a castrate level of testosterone. That's where the studies have all been done on. So it makes it difficult to offer somebody a more advanced agent if they are still having normal testosterone levels. And one thing, of course, the definition of ADT. Avodart, finasteride, 5-alpha reductase inhibitors are not considered ADT. Can you use those medications? Yeah, you can. Will you get some impact as a result of the pathway of suppressing the amount of DHT, dihydrotestosterone, which is the active component of testosterone? You probably will. Will that make a clinical difference for you? I think it's less likely to be able to do it. You may see a reduction in PSA, and we'll see that for individuals. PSA will go down, but does that translate out to an improved overall survival, decreased morbidity and mortality associated with the disease? I think that's a question that is probably, the answer is probably no. I'm not aware of any studies that have looked at it from that standpoint for you. Even when you think about, well, I don't want to do ADT, but I'll consider chemotherapy, Those chemotherapy studies that have all been done all have been with concomitant use of hormonal therapy. So standard of care for metastatic disease is hormonal therapy. Are there ways around it? You can, but I don't know how beneficial you're actually going to be in the long term. If you use a holistic or naturopathic type of approach, I have some patients who have done that. They typically have all progressed fairly quickly, unfortunately, without it. Now, metastatic disease, as we know, is not curable. So you will progress on ADT as well at some point in time. Hopefully, it's a very long time. I've had some men who are 10, 12 years out on hormonal therapy and doing exceptionally well. That's terrific. That's not the norm, but we can see those kind of numbers.
What is being considered as metastatic?
I'm sorry, it's okay, that's fine. We'll go next then.
What is being considered as metastatic?
What's considered metastatic disease? Any disease that's present outside of the pelvis is the official diagnosis or official criteria. So if you had lymph nodes that were above the pelvis, we call the retroperitoneum, that would be metastatic. You don't have to have it in the bone or liver or brain or lung to be considered metastatic. It could be purely within the lymph nodes, okay? Now, bone, liver, brain, lung would be metastatic. I've seen, actually, I just had a very interesting case. It's a gentleman who had a slowly rising PSA on hormonal therapy. All his scans, his MRI, his bone scans were all negative. We did an Axeman scan. We did a fluciclovine scan. He had one site that lit up. It was on the appendix. He had an appendectomy, and he definitely had metastatic disease to the appendix. So just about anywhere one can think of, with some exceptions, you can have prostate cancer spread to. I've seen it along the penile shaft. I've seen it down the urethra. These aren't common, but they do occur. So anything from that standpoint. It's changing a little bit with regards to metastatic disease, and I think the advent and the availability of Urlita that I'll talk to a little bit later has kind of led from that standpoint. Urlita is approved for what we call M0 CRPC. Maybe I should just go on to it now. Let me go on to it. So Urlita is an oral androgen receptor inhibitor. It's very similar in terms of where it works to bicalutamide. You can kind of get the idea. The generic name is apalutamide, so bicalutamide, flutamide, enzalutamide. They're all androgen receptor inhibitors. So it's been approved for non-metastatic, okay, castrate-resistant disease. To your question regarding what's metastatic, in the study, which was the Spartan study that led to its approval, they allowed locally advanced disease, which meant that cancer could be outside the prostate or it could be in the regional lymph nodes, that is, the lymph nodes that are within the pelvis, and it was approved. About 15% of men had lymph node positive disease, but lymph nodes restricted to the pelvis. The approval was based on metastasis-free survival, which is a new surrogate for overall survival. All studies that have typically been done are looking at an improvement in how long men are going to live as a result of that therapy. But we've been making great strides and great improvements, and men are living longer with their disease. We saw some of these hands that went up earlier that said that men are living 28, 30 years, which is just outstanding. Now, if I have a new drug that I want to bring out because I think it makes a difference for that individual, can I wait 10, 15, 20 years to know whether this really improves overall survival? You can, but you may be denying patients a new medication that may be beneficial for them. So the idea was that you find what we call a surrogate endpoint, something else that tells us that this drug, this medication, this treatment works, and we don't have to wait for so many deaths to occur during the trial to see how long men really survive as a result of the treatment. So metastasis-free survival has been shown by a number of studies to actually be a good surrogate endpoint. If you can survive longer free of metastasis, you're going to live longer overall. And that's why they based it on this, and this is the first drug that's ever been approved on the basis of metastasis-free survival. So it significantly improved MFS by 2 years over standard of care therapy, which was hormonal therapy alone, and they used a placebo during the trial, okay? Again, overall survival has not yet been met for the study, even at this point in time. And the study information and the approval came out in February at the American Society of Clinical Oncology meeting in San Francisco. That was the genitourinary arm of ASCO. From that standpoint, the study that we actually participated in Genesis while our clinical trials program was still up actually closed last year. So here we are now a year later, and we still don't have the numbers on overall survival because men are living longer as a result of it. There was a 72% reduction in the risk of metastasis or death. Pretty well tolerated. We can talk about this as well. Those are the most common side effects that are significant. Probably rash is the biggest one. Rash can range anywhere from the size of a dime on the skin up to 30–40% of body surface. And I did see one of those. It's very, very impressive when it occurs, but well managed. There were no grade 4 skin rashes. Nobody had what we call Stevens-Johnson syndrome, where the skin sloughs off, or any of the other severe conditions. So that's good news. So usually all of these are very, very well tolerated. Increased risk of falls and fractures were definitely seen. I talked a little bit about that in terms of frailty and how these medications can impact that and make that worse. One of the things we try and do is to do an assessment of falls. We do a risk assessment on falls for an individual. Are you using a cane? Are you using a 1-point cane or a 4-point cane, as gentleman here is? Much better with a 4-point or a 3-point cane than a 1-point cane. Do you need a walker at home? These are the things. Do you need physical therapy that we can perhaps increase flexibility and strength and balance? These are all factors that have to be taken into account to be able to use medication safely for individuals. So when we look then at the M0, and this is to get back to the point of what is metastasis, one of the newer concepts of metastasis for us is what we call oligo or micrometastatic disease. What's the implication of micrometastatic disease? Oligo, by the way, is the Latin prefix for small amount. So what's the implication of that? Does it behave the same way? Does it make a difference? If I use a medication, for example, this, which is supposed to be approved only for M0, no evidence of metastatic disease, and yet there is some metastatic disease, are they going to respond to the same extent? We know that from a standpoint of looking at these individuals who had positive lymph nodes in the pelvis. Their response was the same as those men who didn't have it, okay? So it does seem to work under those circumstances, and so therefore is micrometastatic disease a major issue for us. The issue also with micrometastatic disease, if you had a single, and I mentioned that before with regards to some of the newer imaging, if I had a single lymph node in the pelvis and I radiated that lymph node, would I get the same responses if I gave that individual hormonal therapy, which would be the standard of care? Studies are underway right now to look at that, to provide, even with metastatic disease, if it's a single focus, can you treat that locally and focally with something like radiation and still get the same outcomes from that? We don't know the answers to that, but we're trying to get there on that basis of that. Okay, I have a suspicion that Erleada is probably going to get approved actually for metastatic disease in the future as well. That's sort of the rumor on the street that'll probably get to that point from that standpoint. We also are probably going to be seeing, maybe by June or July, enzalutamide or Xtandi being approved in this space for M0 CRPC as well. So we're going to probably have 2 agents that are going to be available with that. And we know that enzalutamide or Xtandi is already approved for metastatic disease. So if I give enzalutamide to somebody who has known metastatic disease, they get a response. If I give it to them where we don't think they have metastatic disease, but in reality they have metastatic disease, the same situation from that standpoint. Maybe a lower volume of disease, but the response is probably going to be the same.
Is Erleada one of the fantastically expensive treatments?
Yeah, they're all fantastically expensive. When you look at enzalutamide and Zytiga, you're about $10,000 a month. That's running about the same amount from that standpoint. Yeah. So that's why we come back to what are the things that we're thinking about for our patients. Yeah. What is their copay? Do they have a copay? Hopefully they don't, but those are factors.
Is this one of the is the task force that requires or that sets the standard, let's say, for you have to be ADT resistant in order to qualify for this type of treatment? Or what is this, how do they decide that people are entitled or not entitled to have Medicare cover? Because let's face it, prostate cancer is found mostly in older men, and Medicare is going to pay for it, and they don't want Medicare. They don't want the government to pay for people's treatments.
Well, when you look at any new medication, there is a time process that gets involved when it finally eventually gets approved. We saw the same thing with enzalutamide and Zytiga when they first came out. It took probably up to a year to get not only Medicare, but all the other payers to be able to say that they're going to cover it. Sometimes we had what are called step edits. You had to use one before you use the other. Now, for Erleada, there's no other one that you can use before it. So we wouldn't be seeing anything on that basis of it. If and when enzalutamide comes out and gets approved, I don't know if we would see that on some of the insurance plans. So yeah, Medicare will cover it to a certain extent, just as they don't cover everything with regards to all medications and all treatments and office visits. That's why you have a supplemental plan to help cover that 20% that Medicare doesn't cover. So it's very complex. Thankfully, at least for the more established medications, we have foundations that will assist individuals. There is still a means test for many of them that if your retirement income is still too high, you may not be able to get the full benefit and have your medication provided free as your, generic antihypertensive or something else is going to be covered from that standpoint. I think that's a question that society is going to have to answer as we go forward, asking your representatives, who's making the laws, who's providing that information to us that can help us and be our advocates when it comes to what Medicare covers. Yeah. Well, I think there may be a little confusion. The task force I was referring to first is basically the United States Preventative Services Task Force, and they are sponsored by the government. They are supposed to be experts in the field to take a look at information that is available to determine on screening tests on what should be used and should not be used based on available literature, okay? One of the problems with the USPSTF, for at least when it came to PSA testing, and that there was not a urologist that was on the panel, okay? So, so you can look at numbers and, you can read anything into them. I mean, there are, lies, damn lies, and statistics. That's the old saying, okay? So they can look at it statistically and say it doesn't make sense to do it, but clearly everyone in this room can look at that and will say, well, that's not the case. You could ask them on the panel, because they did have some women on the panel as well, but you'd ask the men and you'd say, if it was you, what would you do? And of course they'd want a PSA testing, okay? And they'd want to be monitored and then screened for it. The current guidelines come down to a shared decision-making process between physician and patient so that the risks and the benefits and the side effects of screening, okay, have a discussion. And that is appropriate. That's the stand that the American Urologic Association takes. Most of the other ones take that as well. But with the data that has come out, and this is now not only in academic institutions, but in community practices as well, and we've published our data as a result of the incidence of prostate cancer since those recommendations came out. Clearly, there's been an uptick in the grade and the stage of individuals. So, wheels of government and these agencies move very slowly, and only through loud voices making your your views known are the way that things get changed under those circumstances.
So who's a typical patient for this medication?
Erlita? Yeah, it's the individual who's been on hormonal therapy or has undergone surgical castration, so a level of castration either surgically or medically, with a PSA that is increasing. That's the easy answer. That's what we consider castration-resistant prostate cancer, as you heard George mention. So rising PSA and a castrate level of testosterone. The study looked at individuals with very, very rapid doubling times, less than 10 months. And so clearly those are individuals, statistically, are much greater chance that they are going to develop metastasis sooner than later. And so those are clearly appropriate individuals. But we also have individuals, and I have them in my practice, that have a slowly rising PSA. They were undetectable, and now their level goes to 0.1. And they may stay that way for months, and then they go up to maybe 0.2. And we repeat it again, it's down to 0.1, and then we continue, and then it goes up to 0.3. So they're sawtoothing their way up exceedingly slowly with doubling times that are over a year, maybe even 2 years long. Are they a candidate to go on this medication and potentially experience the side effects that you see listed there? That's the decision to be made with patient, with physician, determine what's best for that individual at that point in time, and is the benefit, do the benefits outweigh the risks? Or do you simply put that individual on that continued close monitoring and checking your PSAs every 3 months, so that if we do start seeing a decrease in the doubling time, so if they were 24 months, they're now down to 15, maybe now is when we want to go ahead and initiate the therapy, as long as there's no evidence of metastasis. But that's a requirement with this, is that there's no signs of metastasis. There is no requirement that you get a PSMA scan or an Axeman scan or any type of PET imaging. What was used on the study was standard technecian bone scan, as well as CT and MRI. And the patients underwent those imaging studies every 3 months. In fact, I, as an investigator, was blinded to the PSA during the course of the study. So I didn't know what the PSA was doing for these individuals, because they were looking at metastasis, they were looking at radiographic progression from that standpoint. So it's kind of interesting on that basis of it. But that's a discussion to be able to say, if you've got a very rapid doubling time of your PSA, you clearly are going to want to do this to try to forestall the development of metastasis, and that's what we showed from that aspect of it. So that's the ideal patient, but other patients with rising PSA could certainly be considered. I know, forgive me, yes.
I wanted to get your position on biopsy versus MRI, and a little context behind that. I did see one of your urologists in your clinic about 1.5 years or so ago. You recommended a biopsy based on a 4K score, and rising PSA was around 7. But I went instead to see Dr. Schwartzberg and got a Tesla 3 MRI. And my GP gave him the okay to do that. And it turned out I had inflammatory prostatitis on 2 of the lobes. And so that's where I'm at. And now I'm up to a 9, about a little over a year later. And I'm just trying to figure out which direction to go.
Yeah. Well, obviously it's difficult for me to actually give you, any type of specific information here, probably not germane, but at least in general, okay? Multiparametric MRI, I think is a great tool. There's a lot more information that's recently come out, and that came out of the European Association of Urology meeting that was held, I think it was just earlier this month or the end of March, where they presented some data with regards to using MRI as a screening modality before doing a biopsy. We recognize that multiparametric MRI is really most useful in identifying high risk or high grade cancer. That's where its benefit is, its power is located. It does not do a good job in identifying low grade cancer. Now, that would be your Gleason 3-3, your Gleason 6. Now, the 3-3 is simply that we think about, well, if it's 3-3, we really don't have to worry about it. It's not a major player. It's not going to affect you in the near term, and probably maybe not even in the far term. Those are why we put those individuals who made those diagnoses on, we offer them active surveillance with some caveats. And that really comes in to say, is MRI the answer? I don't have the answer to that. I think it's a great tool that can be used. We know that MRI probably has a false positive rate of about 20%. That's 2 out of 10 men. Do you want to miss 20% of men in order to be able to avoid biopsies in those other 80? If you're in that 20%, if you're one of those 2 individuals, may not be a good number for you from that standpoint. 1, 2. It doesn't identify Gleason 3-3, but not every 3-3 is the same. Not every Gleason 6 is the same as every other Gleason 6. We've seen that simply by doing genomics, and there's some evidence that some percentage of those 6s are actually more aggressive than your routine run-of-the-mill 6. Okay. Also, if you look at the criteria for a very low risk or a low risk per NCCN guidelines, you're looking at a number of factors. You're looking at the number of cores that are positive. You're looking at PSA density numbers. Is an individual with 2 cores of Gleason 6 with 5% in each core, is that different than that same individual with 60% in each core? I don't know. That's a good question. I don't think we have the answer to that. Okay? I think MRIs can be helpful in those situations, because clearly when we do the standard biopsy, which is transrectal, we're approaching it posteriorly. It's part of your prostate that sits anterior, okay? Or maybe you've got a large middle lobe that's growing into the bladder. We don't biopsy those areas routinely, okay? So you can take a look at those with an MRI and see, did I miss something in there that is concerning that we need to address from that standpoint. Doing that MRI perhaps before the biopsy, I think, may help that from that standpoint, because then, as in perhaps in your situation where it appears to be most consistent with prostatitis, okay, that's terrific. If I have somebody who's got an abnormality of PIRADS 4 or 5, the grading scale on the MRI, then I can either go ahead and do MRI-directed biopsy or do an MRI ultrasound fusion biopsy and be able to answer the question, really, is that there? Okay? And when you look at those 4s and 5s, I just biopsied a gentleman with a PIRADS 5 2 weeks ago. It was negative. Okay, there's other reasons to explain a 5 as well, but at least we know from that standpoint on an individual. So there's a lot of unknowns here, and there's a lot of gray area that we would like to have one definitive test that says, is it there or is it not there? We don't have that kind of a test. So we're going to have to use a lot of information to try and fill out this picture. As I tell my patients, what I have is I have a bunch of puzzle pieces. I don't have the picture puzzle box top to know what the picture looks like. So I've got to find as many pieces as I can to see what this picture is and make our decisions on the basis of that. Okay. So, but certainly a possibility. Okay. I'm not sure where I'm going next. So I've been on that side. Let me come here.
On the biopsy, you mentioned the anterior not being covered. Is there any trade-off? I've seen some studies on the transperineal versus the conventional biopsy for reducing infection as well.
Sure, yeah. There's no question that transperineal reduces infection rates. You clearly can get to the anterior prostate, which you can't really do well, although you can angle your needle off if you've got a target, and it's more painful when we do it that way, because if you got a lesion in front and I'm driving my needle all the way through your prostate, I'm not getting your peripheral zone, which I typically would do when I do a transrectal, right? So, but it's a more difficult procedure to do. It requires, in many places, they'll do it under a mild general anesthetic, or at least a twilight type sleep, because it is more painful to go through the perineum. You can numb it up to the best, but it's still going to be more uncomfortable. So and I will tell you that by training, most urologists are not trained on transperineal approaches. They're trained on transrectal approaches. It's just much easier, quicker, faster to do it in that fashion with that. So there are some technical and drawbacks to in terms of doing it from that standpoint, but it does offer that possibility with that. A lot of the infection rates have decreased now as a result of other regimens to assess. For example, rectal cultures to determine whether there's resistance to the standard antibiotics that we use. Dual antibiotic regimens, which is what we use, has reduced the risk of sepsis down to like 1% or less. So it is conceivable to be able to do that. There are ways to be able to get to the anterior area, but doing it blindly is not a good way to do it. If you have ultrasound, MRI fusion technology or the MRI directed, you can get to some of those more anteriorly located areas, but some of them are not accessible other than probably through a transperineal approach. Beck?
Thank you. I see some similarities between Erlita and Casodex. Could you comment on high-dose Casodex treatment?
Yeah, Casodex high dose has been used principally in Europe. That's what they found on their data. In the U.S., it never was officially approved in high dose. There clearly are more side effects that are associated with high dose Casodex as well, such as gynecomastia, breast tenderness, nipple tenderness. You don't typically see that. In fact, it really wasn't seen in Erlita, so you don't see those kind of issues. One of the things with high-dose Casodex also has been used as monotherapy. In the United States, monotherapy, again, was not specifically approved. That's not saying that individuals haven't tried that and been given that. They certainly have. I tried to do it for a while, but I ran into insurance roadblocks. It wasn't going to be paid for by the insurance because it wasn't an approved method of treatment. So it certainly can be beneficial. If you're going to use it as monotherapy, you do have to use 150 milligrams. You don't get enough reduction in the effect on the androgen receptor at 50 milligrams daily, which is what we typically use when we combine it with androgen deprivation therapy. So at least in the comparing and contrasting as single agents from that standpoint, you may well get some of those similar side effects if you happen to use Erlita as a single agent. It's not approved in that fashion. It's only approved with hormonal therapy or androgen deprivation therapy at the same time. Maybe one reason that we're not seeing those side effects that you can see with high-dose Casodex on that basis. I'll go next door.
There was an article in the New York Times a few weeks ago describing the genomic testing of patients with low risk or very low risk assessments as a means for assigning a score or a likelihood of aggressive progress, or helping make a decision between active surveillance and something more aggressive. Right. Is that?
Well, we do use that. One of the problems with some of those genomic tests is that you have to have a certain amount of tissue material to be able to run the test. And many times we'll get 3-5% of a core that's cancer, so they meet the criteria for very low or low risk. There's not enough tissue to be able to run it. So you really are looking at 10% or higher to be able to run that. I'm sorry? Well, they certainly claim that there are. I think you can look at the studies and what they've reported out, and you can nitpick it a little bit and find that there's some data there that just doesn't really seem to really hold up as well as we'd like it to hold up. But from a practical perspective, we're certainly using those as a guide again to make that decision whether this is an individual who should stay on active surveillance or not. My own personal use is I tend to use it more in the low risk to intermediate risk than the very low risk, just on the basis that they are very low risk. Usually those volumes are very low in terms of that, and I simply can't even run the test. So I feel much more comfortable after doing appropriate assessment from a standpoint of the pathological review, as well as I use a lot of MRI, so that helps me out as well. I typically try not to do the MRI now too early because I've seen a lot of problems with early use and hemorrhage in the tissue, which tends to obscure things. So I tend to wait at least 4 months, preferably more towards if I think they're a good candidate for active surveillance, I'll do it before the confirmatory biopsy, which is typically anywhere from about 6 to 18 months later, more commonly maybe towards more towards the year mark. And I'll use that from that standpoint to see if I see anything that's changed on that basis of it. But I do use those genomics from that standpoint.
Just about, for a order of magnitude of the cost of the genomic test.
I remember I think a cash price is still between $2,000 and $3,000 if I'm not mistaken on that. So again, looking at insurance and so forth, and there's a couple of IPAs here in San Diego County that don't cover it well. So yeah, it's problematical, but we're seeing that all with these more advanced diagnostic modalities as well as the advanced treatments. Yeah. Yeah. All right, let me move on and then we can answer some questions. Yep, I went the wrong direction. Okay, here we go. So in terms of immune therapy, so prostate cancer is considered to be poorly immunogenic. It doesn't generate much of an immune response, unfortunately. And that's why one reason we're probably not seeing the responses quite as much in prostate cancer as we've seen, for example, in melanoma or lung cancer, or even with some of the other genitourinary malignancies such as bladder and kidney. We've had Provenge, sickle cell T, out for a long time. I'm an advocate for it. I think it's beneficial. I believe in the data, and that's what you have to do if you're going to use Provenge, because there isn't a way to be able to measure the response. But nonetheless, so in the newer agents, we're really looking at what are called checkpoint blockades, as well as vaccine therapies. Unfortunately, some of the vaccine therapies have not panned out as we would like to. Again, this is a very, very complex and difficult area as a result of the really the makeup of prostate cancer. Looking also at DNA mismatch repair deficiencies, there's mechanisms for our DNA to repair itself. Every time our cells divide, little nicks and cuts occur within the DNA naturally, and so our cells have a way to try to repair that. And in some situations, we can capitalize if there's a mutation that there are deficiencies in the DNA, that we can utilize medications and develop medications to be able to work at that level. So in general, they're kind of looking at two main ways to try to approach this, both from a standpoint of boosting the immune response as well as to modulate the immune response. One of the things that tends to happen with prostate cancer, it tends to stay well hidden from the immune system. Okay, it's like it's behind a veil, and our immune system doesn't really see it. So if we can boost our immune response, they can make it more identifiable. That's one thing that Provenge has tried to do in terms of working at the prostatic acid phosphatase present on the cell surfaces, that it can now make itself present to the immune system. But we also have to think about immune modulation, because once we start boosting the immune response, it can sometimes kind of go off as basically a wheel that keeps turning and turning, and that immune response then can actually start to affect other parts of our body. And one of the things you see with some of these immune agents, and we've seen that with melanoma as well as lung and kidney cancer, is that you can start developing inflammatory responses in other tissues. You get basically an autoimmune response. And so you can see hepatitis and colitis and pneumonitis and all sorts of other itises, other areas of inflammation, which brings along a lot of comorbidity associated with the use of these agents. So one thing is then to try to modulate that response, try and tone that part of it down, and still maintain the response against the cancer that we're trying to cover from that standpoint. There's some novel therapies I looked up on a recent review, probably something like 60 different clinical trials going on at various combinations or single agents that are trying to be used. Myeloid-derived suppressor cells are one of them. They tend to promote progression of the tumor, as well as resistance against our immune agents. So again, multimodal, bidirectional approach, both to decrease progression and to reduce the resistance, will make these medications much more helpful. The bottom line still remains, unfortunately, for immunotherapy is that we don't have anything that has been approved, not to say that they're not being used under certain circumstances under clinical trials, but we don't have anything that's brand new beyond Provenge that's been approved. So again, the microenvironment where that cancer cell is living is really suppressing the immune system. So either it turns it off or makes itself hidden from that standpoint. We're trying to basically both turn on the immune system as well as to modulate the immune system. It's like having a governor on the engine, okay? So that it doesn't rev up too high, but revs up just enough to be able to get you where you need to go. Combination therapies are probably, as I mentioned before on that timeline, is really going to be very, very important. It's probably the future wave for treatment of all prostate cancer, similar to that study that I alluded to, that Dutch study in terms of multimodal, simultaneous approach to try and take care of all the different subtypes of prostate cancer. It remains investigational, unfortunately, at this moment in time. So again, we've got some folks here that I think have been on Keytruda that have had some very, very good responses to it. They're not a lot of them, and they're not enough of them to really bring that yet to a point where we can say every individual who has failed a certain line of therapy and has certain genetic mutational pattern that will allow the use of them. We're not at that point yet, but we've made great strides here, certainly since 2012. Here we are in 2018, within the last 6 years. The future is bright. We just had a new agent, novel agent, really, that's just been approved, as I said, for the M0. That's the Urolita. I expect more will be down the road. Lots of work being done on it. Okay.
On this, is there a recommended place to go where you can follow the latest on these type of therapies?
Are you looking for a website per se from that standpoint? I don't have one that I can give you, directly. Some of these sort of flashes come out like on Medscape. I see a lot of those things coming through, a lot of updates from that aspect of it. So Medscape, I think, is a good point. I think that's available to you all from that aspect of it. Some of you all in this who have a little more time to spend looking at and the internet may have information too. So use your networking here.
Yeah, the Society for Immunotherapy of Cancer, the membership is available to us as patients for free. And they have seminars, they have tutorials, they have meetings and stuff. It's really a great resource. So I think it's istc.org, Society for Immunotherapy of Cancer.
Question over there.
Are you going to touch base on intermittent hormone therapy?
I can answer questions about it.
Well, my first one is that mine is aggressive. I went from 1 to 22 in 2 years. But it's the set itself contained. It's within the prostate. Obviously it's full, but it hasn't found any place in the body.
Great, that's wonderful.
And so, because I'm doing my own thing now, the doctor says, well, whatever you want, I'll help you. So I'm doing intermittent, and I go on it for 3 months, I go off it for 3 months. And it's been working 5 years so far.
Great.
But how do you know what's the proper amount? We just had this discussion a couple of weeks ago with my doctor, trying to figure out, should I stay on the drug for, say, 6 months? I'm on Lupron, by the way. 6 months on and then a couple months off, or 6 months off? He said it doesn't matter how long you're on it. You're only going to get your 3 months off because it rises so fast. I'm at 6 within 2 months.
Yeah, I mean, you're one of those folks who clearly your testosterone recovers exceedingly rapidly. You don't. I mean, I've given an injection of Lupron to a patient, and they don't recover their testosterone for 2 years. Okay, I've got others that as soon as like the day afterwards, when they would be due for their next injection, their level starts to go up. And so, yes, I would agree from your particular situation, what you're describing, that your time frame off of it is going to be relatively short. I think one of the thoughts about intermittent therapy that made it attractive is that if you could continue to keep those cancer cells responsive to and needing testosterone, okay? And all our cells work on receptors, so you want to keep those receptors active. So by pulsing therapy, you continue to tell those cells that, hey, I need testosterone. I need to be taking it. And so therefore, when you take it away, they're going to respond. Your PSA level is going to come back down again. That's the theory on how it works. It's felt that intermittent therapy under these circumstances is, quote, non-inferior to continuous therapy, that it's no worse, okay? And of course the benefits may be that we don't allow castration resistance to occur as readily, that's one thing. And two, you get to recover, and so your period of time that you're going to be experiencing side effects is going to be much shorter than if you were on continuous therapy for yourself, okay? There was a study, and very small numbers again, something like 10 or 12 patients, I think it was done back in North Carolina, where they had individuals who were castrate resistant. And in a very bold move, they actually gave those individuals testosterone. So they gave them testosterone. And actually, some of them were able to be reconverted to hormone-sensitive from castration resistance. So now the idea is, well, who are those individuals, and could you identify them and personalize that to say, individual A is a good candidate to do that, but individual B isn't because of certain markers and characteristics of their particular cancer. There's no answer to that as well. So, I mean, if you're riding a horse and that horse is getting you where you need to go, you stay on that horse until something else tells you need to change. So that would be the thing that I would say to my patients who I do have on intermittent therapy, and that's how I manage them.
So with this game that I'm playing, if 22 was my highest point of PSA, and now it's only 6, should I asked my doctor, and he said he didn't know, how long do I wait? Do I wait till it gets to 22 and I go back on the drug? Or do I, where's my cutoff point? And nobody knows that answer.
Nobody knows the answer. And so everybody's doing their own thing. Everybody would say, the likelihood that I would say if I have an individual whose PSA is quite high, we get concerned, right? Because remember, you know what PSA stands for, right? Physician-patient stimulated anxiety, okay? Right, so it's just as anxiety-invoking conditions for the patient, as well as for us, as physicians. You say, is this the time? Should I be giving them something from that standpoint? So you had a scan at 22, your scan was negative, everything looked fine, it was still contained within the prostate, you're probably more likely to be that way. But since, my crystal ball is kind of dim, I don't know if something is morphing with that cancer and that instead of now 22, it's going to go somewhere at 15. I don't know the answer to that. So there's lots of different regimens to take. Some people would say, I'll retreat you when you get to half of what your highest PSA level was. So it would be 11 in your particular case. Some may say, well, let's just wait. You're doing fine. Let's wait and gamble a little bit, re-image you when it gets to 22 or thereabouts. If it all looks good, we'll go ahead and retreat you for that period of time that we planned for. There's no way of knowing. That's that long discussion to have with your urologist as you're doing to see what is the comfort zone for you as well as for him. Unfortunately, there's just no data to it. Yep.
The City of Hope Cancer magazine recently had many articles on CAR T-cell therapy. Is there any application to prostate?
Well, there may be. There are some studies that are underway that are looking at CAR T and changing those T cells and reinfusing those adapted and altered T cells specifically against prostate cancer. But there's no data yet out from that standpoint. I think in the hematologic malignancies, we're certainly seeing CAR T usage, but not yet in prostate cancer beyond clinical trials.
Yeah, this is all new territory for me. I just starting off on this path. And because of a rising PSA the last few months, I just had a biopsy a week or so ago. Okay, so I kind of insisted because it was recommended to have the MRI done ahead of time, which I did, and as a result of that, the urologist found 3 areas of concern, so that when he gave me the total, we took the samples, the core samples, he took 18 instead of 12. Right. Okay, so I'm going to meet with this urologist again to go over all that, over the results of this biopsy. So what should I expect besides the Gleason score? I mean, is he going to talk about options, or where do we go? I'm kind of confused about the deal where we're talking about urologists, and where do oncologists, do they come into play, or do they both trade hats, or what?
Yeah, so, prostate cancer traditionally has been, at least initially from diagnosis and initial treatment, has been in the realm of the urologists. The oncologists tended to be coming on the scene later. That still tends to be the case because your biopsy was done by a urologist. So that discussion is going to be held with your urologist. If there is an indication for definitive therapy, such as radiation or surgery, if he's a surgeon and you elect to do that, then he would continue to take care of you and monitor you until such time that you're 20 years out and your PSA is undetectable and probably doesn't need to see you anymore. If you go through therapy, surgery, and unfortunately it was not successful and the PSA starts to rise, they're usually the ones who will start therapy for you, or at least have the discussion with you, maybe ask for a second opinion from oncology or something that you might ask, that you would want to see an oncologist and get another opinion from a non-surgeon standpoint, non-surgical standpoint, potentially. So for the most part, oncology is going to be there either as a confirmation of a choice that's already been made, or for treatment of advanced disease. And that's more commonly where you'll see the oncologist being involved. So I will presume that discussion with you is going to be go over the results, how many cores were positive, the distribution, the Gleason grade. You already have an MRI that's given you a lot of information already with regards to the potential for extracapsular disease, extension of disease, lymph node status. All that's already been accomplished by having that MRI, which I think offers another advantage to doing MRIs early before a biopsy. And then that discussion will be held with you as to what direction to go on the basis of those findings. And that's really what you're going to wind up doing. And those discussions will branch out based on the treatments available, what are the risks, the side effects, the potential complications of each of them, as well as what your tolerance is for those. What are your situation? What are you willing to deal with? What's your risk of incontinence or impotence associated with surgery, or any other side effects of a major operative intervention? Okay, so the same thing would then be had with radiation. And if you're thinking of radiation, I would definitely at least get the opinion of a radiation oncologist first before making that decision. And that's a good thing to do, especially if both therapies are available, both therapies are indicated. You definitely want an expert to be able to tell you from their perspective what you can expect, what you can accomplish with that, what your risks are. All of that should be done. So that's the direction I would go. So making that informed decision with as much information as possible.
Is there a line for when you would ask for a second opinion?
I think a second opinion will be for your own confirmation that what you've been already told is correct. If you trust your physician who you're speaking to. If you don't, obviously you might want to get another opinion. I've had some patients, they don't like what I say, and they go and they get a second opinion, and they come back to me and said, yeah, you were right, and this is what I want to do. I mean, there's lots of reasons to get a second opinion. When I tell my patients, if you want a second opinion, by all means, go and get one. I'm very confident with what I tell you that is the correct information and why I recommend it. I do let my patients know the wherefores and the whys. I'm making that recommendation to them, and I break that down in great detail, because I recognize that you're sitting there in that black box and you don't have that kind of information, and I'm trying to make it a little bit grayer so you can see a little more clearly your way through to see what's going to be your best decision. What I don't want is my patient coming back to me and saying, you didn't tell me about this. That's not where I want to be. I want you to make that. So you can look at yourself in the mirror in the morning and say, I made the best decision for myself. Okay.
Is there, could you make a commentary about the inevitability of recurrence of cancer, no matter what you have done? Especially for people who had a radical prostatectomy and therapy, immunotherapy, radiation and all that, that no matter how long, it will come back, correct?
No, no. I do think prostate cancer is curable, okay? I have patients who are 15, 20 years out and their PSAs are undetectable. They had radiation, they had surgery, and there's no detectability. The likelihood is extremely low under those circumstances. Again, do I know that one cell didn't get out of the prostate at that point? I can't tell you that, okay? But I don't think a hard and fast statement that it's inevitable in every patient that it's going to come back, I don't think that's true from that standpoint. So unfortunately, we do know that some individuals, it does come back, it does persist. It's really not coming back, it's a persistence of it. That mode of therapy was inadequate to achieve the goals that was set out for. If it was definitive therapy, the goal was to get rid of it completely from that standpoint. There are indicators from the initial diagnosis as well as after treatment that may indicate a greater or lower chance that it is going to ever come back or persist for that individual. But I don't think you can say that it's inevitable.
Yeah, for me, it's been about 3 years and I've been below one. It's hasn't been come back at all. The question I have is sort of outside the cancer realm is I get all these emails, I guess, ads for supplements all the time. Is any of that stuff any good? I mean, the vitamins that give you a healthy prostate, whatever.
Well, again, they're supplements, and so there is no double-blind, placebo-controlled study that's going to tell you that it makes a difference for you, okay? I mean, it doesn't exist, okay? They're not regulated by the FDA, right? So could they be beneficial? Sure. I mean, again, first thing is to do no harm, okay? So if it doesn't cause harm and it is possibility of providing some benefit, and you can afford them, they don't give those things away for free, I understand they're quite expensive, then you can go and try it and see if it seems to help you. It's going to be a clinical trial of one and determine whether that is, but what are you comparing it to? So yeah, but there's just no data on it. Well, for your case, if you've already been treated and so forth, yeah, I mean that's what you're looking at. You're looking at that close monitoring to ensure that PSA does not rise.
We have time for 2 questions.
George, you pick up because I'll take care of this.
What do you find as you said possible cure? I've had several treatments. I started with a radical prostatectomy done by Dr. Salem, and then I had proton therapy, and now I'm under the care of a medical oncologist. And I had a PSMA scan just done at UCLA, and they located it in my hip, and I'm going to get radiation by Dr. Sarazi. I heard that there's that possibility once it's radiated, slight chance, is a scopal effect?
Not familiar with that.
They say sometimes it stimulates the immune system to start attacking the cancer.
Yeah, radiation can do certain things from that standpoint. That as you break, the idea is those cells are breaking open and they now become more accessible and apparent to the immune system, and you can see things from that standpoint. So, again, metastatic disease is something that we look at and we say, we don't have a guaranteed treatment to get rid of it completely. So we try and control it. Now, does that mean that a given individual may not get that kind of response and get a prolonged response, a remission, if you will? We don't know the answer to that. Again, we're looking at a focal event that's going on and nowhere else that we know of. The problem is that if it's there, what's the chances that it's somewhere else, Okay? We may have a better idea about that as we go forward, for example, with circulating tumor cells or circulating tumor DNA or circulating tumor antigen, where you're doing a liquid biopsy as a measure of response to a therapy, so that if you have a certain count in the bloodstream and you do a therapy, you intervene, and that level drops down to 0, is that conceivable? Possible? It's conceivable. Is that going to be practical? And can we achieve that? I don't know the answer to that, but that's going to be a better way probably to assess those individuals, okay, to see what the response is to the therapy based on the total cell count, okay? We don't have that way to be able to do it right now. We've certainly seen individuals, for example, who have a rising PSA, and you do a technecian bone scan when the PSA level is 20, it's negative. You do it when it's 40, it's negative. You keep doing them until finally, over 200, and all of a sudden it shows up. Does that mean it wasn't there beforehand? No, it clearly was there. We simply couldn't identify it on the basis of that. So from going from technetium to a PET agent to some other process to a blood test to identify the number of cancer cells that are present, clearly you're increasing your accuracy, and I think that can be much more prognostic, which is what you're looking for. You're looking for a prognosis, whether that's going to be achievable or not.
All right, one more.
What? Okay, I'll come. I stay come over here. So, and I'll be around afterwards to answer questions. So, yeah.
And I've gone through cancer treatment with IMRT about 6 years ago. Mine's come back. But my question really, one thing I was hoping that we'd hear today, we've heard before, is many different treatments for prostate cancer. There are 16 or so different treatments. But my question specifically, immunotherapy, and following on the other gentleman's question, some of the treatments, be it nanoknife or HIFU or brachytherapy, in theory breaks up the cancer cells or kills the cancer cells, and then the body starts to teach itself to deal with it, the immune system. And is there truth to that? And is one treatment better than another, or that's more likely to happen?
Yeah, I don't think there's any data that says one treatment is better than the other. I think that from a standpoint of other sort of animal model type therapy in studies that have looked at that there seems to be a response to a heightened immune response from that standpoint. I don't know. There may be a study that's looked at that in humans. What you would wind up having to do is probably get into that tissue and see what kind of immune response is actually going on from that standpoint. I don't know. I don't think there's data that says that, as I said before, any one treatment is better to accomplish that or another from that standpoint. So it's an intriguing idea. I've seen that, again, as I think an animal model, but not in the human model to say it definitively is occurring. So beyond that, I don't have much information for you. So okay.
Thank you.